Hi, my name is Barack Gaster. I'm a primary care doctor, professor of medicine at the University of Washington, and this is the second segment in my series, Dementia in Primary Care. And in this segment, we're going to be talking about how to do a cognitive evaluation in a primary care office. As you remember, here's the series of segments for this series. This is the second one. At the last segment, we did an introduction to dementia in primary care. And for this segment, we're going to be going back to this case of the 82-year-old man who was in your office for a wellness visit, generally healthy. He has hypertension, osteoarthritis, takes losartan, occasionally ibuprofen, and rarely takes zolpidem. And he happened to mention at that visit that he's been worried about his memory. So we went through the other things that you might be tempted or end up doing in response to somebody mentioning that at an annual wellness visit, but we really focused in on this last option, which really is the most effective and efficient thing to do in a primary care setting, which is to schedule him for a follow-up visit, which ideally would be a longer visit with a family member present, because you really want to engage and say, gee, I hear your concern and I do want to evaluate this further. And so today we're going to talk about how to do a follow-up visit to evaluate cognitive concerns. There's really two segments to a visit like this. The first is to do the quick and easy screenings for reversible causes and contributing factors, and then do a quick assessment of cognitive function, which you can do in a primary care setting. In terms of the reversible causes affecting cognition, the two easy ones that we probably all remember from medical school are to look for reversible causes of cognitive impairment. So really super quick blood tests for vitamin B12 deficiency and thyroid dysfunction. Those are two blood tests that you probably could have ordered at the last visit and then review the results at this follow-up visit. And you just definitely want to do some screening for looking into what somebody's alcohol use might be and could they be suffering from depression. I want to share with you maybe the most embarrassing episode of my 10, 20 years in practice, sort of evaluating patients with memory concerns in primary care. So I had a patient probably about 15 years ago who said that they were concerned about their memory. He was really, really concerned. He wanted the big full workup right then because he was so concerned. So I ended up sending him to a neuropsychological evaluation. So we went and saw a neuropsychologist. He sat down for the full 2 hours of assessment. I got back the beautiful 30-page report from the neuropsychologist that went through all the batteries of tests that they ran the patient through. And at the very last paragraph of that 30 pages, the very sort of last couple of lines were, so this person does for sure have cognitive impairment, but he probably would be much better off if he didn't drink a bottle of wine every night. And I was so embarrassed, like here, a patient who I'd known for many years had never shown any signs of impairment from drinking, no signs of problem drinking. But here I had forgotten to ask about his alcohol intake. And lo and behold, when he did stop drinking a bottle of wine every night, his cognition improved a lot. And so just don't forget to ask patients about alcohol use, because maybe they were perfectly able to drink a bottle of wine for decades and decades through their 30s and 40s and 50s and 60s without it impacting their lives negatively. But once somebody gets to their 70s and 80s, all of a sudden that bottle of wine really can have a significant cause significant impairment in their cognition. You want to look at their medication list. So we all have patients who take Ambien for insomnia. We try to avoid it because we know of its side effects. But there are people who end up coming to us on Ambien, and we end up keeping them on it after attempts to try to get them off it. And maybe that was okay when they were in their 40s and 50s and 60s, but now that somebody's in their 70s and is worried about cognitive function, really that's the point to make a case that, we probably could improve your memory a lot and improve your just general thinking if we were able to get you off Ambien. Same with oxybutynin, medication that is often used for urinary incontinence that can sometimes be somewhat helpful for treating that symptom, but really does have a high risk of causing cognitive impairment in the elderly. And then the two that are the hardest to remember and the ones that are not necessarily intuitive are asking about sleep apnea, so screening people for sleep apnea and sending them for a sleep study if there are concerns, because many of us have probably had patients who had impaired cognition, started using CPAP, and their cognition got a lot better. And same with hearing loss, which is just a super funny sort of chicken and egg, in that, is it the hearing loss causing cognitive dysfunction, or is it the cognitive dysfunction that seems to be causing trouble with hearing? So hard to tease apart. There's no question, though, that as people develop worsening hearing, it is almost indistinguishable from cognitive impairment in the way that people just kind of shrink down and self-isolate themselves from the world if they can't hear what's happening or can't understand what's happening around them. And so, again, so many patients who have hearing impairment, who have been reluctant, resistant to wearing a hearing aid, this is the moment to really make the case that if we could improve your hearing by wearing a hearing aid, it really would improve your cognitive function, improve your ability to interact with the world around you. And so then, in addition to those screenings for contributing causes or even causative causes, so important to then do a cognitive evaluation in the primary care setting. And this is something that we in the primary care setting really need to be comfortable learning how to do and doing well, because this is just such a common scenario. And it's just not practical for us to refer all of our patients somewhere else for evaluation like this. And it's really not what patients want. Patients are often reluctant to go and meet someone who they've never met before for a memory assessment if they feel like maybe their memory is just fine. And so we really want to combine a input from a family member, observer, and a 10-minute cognitive assessment, and put those together to assess somebody's cognitive function in a primary care setting. That family observer cannot be overstated. It is probably the biggest pitfall that happens when people go to see a neurologist, a dementia expert. They show up by themselves, and even the world's best dementia expert really cannot adequately assess somebody's cognitive function unless they have an observer there who can say how the patient has been doing, only because the report from the person themselves is often going to be sort of tricky and not as rich in the amount of information that it can give you. So you've got to have the family member at that follow-up visit, which is just another really important reason to not to try to evaluate somebody's cognitive function then and there when they first bring it up, but really set up a follow-up visit and just sort of bring that point home so clearly that you really, really need to have somebody who spends a lot of time with them accompany them to that visit. And so what are you going to ask that person? I like to boil this down to 3 questions that I ask them. It's pretty easy to remember these questions. There's also a well-validated questionnaire that you could use that is really easy to find online. It's called the AD8 questionnaire that just runs through sort of a structured set of questions. Or you can just sort of, what I do is just remember these 3 questions, and I find them pretty easy to remember. And it's a pretty smooth and efficient way to interview that observer to get invaluable information about how the person is doing. The 3 questions I ask are, does it seem like the person is repeating the same question again and again? So 30 minutes later. So it's not just that they don't remember the answer to the question, but they don't even remember that the question was asked. And that is a really significant red flag for cognitive impairment, more than just normal aging. But it's so important to keep in mind that dementia is not just memory loss. It's not just short-term memory loss. It's really all of the other complex cognitive things that our brain does, and executive functioning, sort of sequencing and organizing complex tasks is maybe the most important of them all. And so the way to really try to assess for that is a common complex task that someone has always been able to do without problem is all of a sudden starting to cause them trouble. And the holidays are a good marker for this, because often there is a sort of a traditional thing that somebody does for every holiday that is a relatively complex task that they've done for many, many years in a row without any trouble. Like, for instance, making a complex recipe for Thanksgiving dinner. They've made it so many times that they don't even really need to consult the recipe, because it's just kind of an automatic sequencing of events. But then all of a sudden there's one year in which sequencing the steps in that recipe becomes so complicated that it really stops them and they're unable to do it. And that is a big red flag. Another one might be, again, sort of pegged to the holidays, is if somebody's job has always been to put up holiday decorations, and one year they're sitting with all the decorations around them and they can't quite figure out what is the organized sort of sequential steps that they need to get those decorations up. Another really important domain of dementia is problems with spatial function. So you're losing the ability to really keep track of sort of yourself in the world. And a good way to ask about that is somebody who gets lost in a route that they should know really well. So this is not getting lost somewhere where they've never been before, but this is a path that they have followed sort of numerous, countless times, where all of a sudden one day they're sort of stopped in their tracks along that route and are not sure where they are, which way to go. That's a big red flag. So it's not hard to get used to asking these questions, and those are really the key types of information that you want to get from an observer that you absolutely need in order to evaluate somebody's cognitive function in a primary care setting. So next, you're going to do some kind of a 10-minute cognitive assessment, and there are many tests out there. The one that is the best validated and has the best sensitivity and specificity for using in a primary care setting, especially for distinguishing normal aging from mild cognitive impairment, is the Montreal Cognitive Assessment. It is more sensitive than the mini mental status exam, which is what probably most of us learned in medical school. Crazy thing has happened to the mini mental status exam over the years, where the owners of the mini mental status exam, they own the copyright, and they really do require a $2 fee anytime it is administered in any kind of a clinical setting. So the MOCA is free, does not require a fee like that for giving it. It's very easy to score on a 0 to 30 point scale. It does take about 10 minutes. Less than 26 on the MOCA is considered abnormal. Like with any test, be aware that there is a significant gray area where people will end up with a score between, say, 23, 24, 25 that is below normal, but it is still kind of in that range where the specificity is still only so-so in terms of distinguishing mild cognitive impairment from normal aging. And so uncertainty is unavoidable. And at that point, you might consider a referral, you might consider a neuropsychological evaluation. This is really a shared decision with patient and family, but this really is a relatively easy and efficient test to give in a primary care setting that gives us lots of really valuable information. And so then we're going to put these two things together. We're going to put together the observer input together with the MOCA result and assess somebody's cognitive function in primary care. If the MOCA score is low and the observer reports that there has been a gradual and progressive change in somebody's cognition over time, especially with those red flag type observations that I mentioned, and they have a loss of trouble doing some activities of daily living, then you really can make a solid diagnosis of dementia in the primary care setting. On the other hand, if their MOCA score is kind of in the middle, if it's 24, 25, 26, and the family does note some cognitive changes, but they are still independent and doing their activities of daily living, then the diagnosis is mild cognitive impairment. We're going to talk in the next segment about how to talk to patients about a diagnosis of mild cognitive impairment. But the bottom line is you really do want to voice concern, some reassurance, and just make sure that that's something that you're going to be following sort of closely over time. But in the meantime, there is so much that you can do to help them with their thinking. So you want to address their alcohol use. You want to evaluate their medication list. You want to consider a trial of an SSRI if they have signs of depression. You want to make sure you screen them for sleep apnea and hearing loss. And one of the sort of last segments that we're going to talk about in this series is advanced care planning. So this very well might be a super important time to talk to somebody about their durable power of attorney for healthcare and who their alternates would be. So what is mild cognitive impairment? I can tell you when I was in medical school, I hadn't really heard this term. It is a relatively new diagnostic category. Textbooks say that you don't actually sort of technically qualify for a diagnosis of dementia unless you have progressive loss leading to loss of independent activities of daily living. So if you have cognitive impairment, a low MoCA score plus some red flags on observer questioning, but somebody is still fully independent with their activities of daily living, then they don't technically have a diagnosis of dementia. The more appropriate diagnosis for somebody like that is mild cognitive impairment. The tricky thing is that a large majority of people with mild cognitive impairment, 70%, 80%, maybe more, do eventually progress to dementia. And so among all of the people with mild cognitive impairment, actually a very large majority of those people do have early Alzheimer's disease. And so we're going to talk about how to talk to patients about that and what to do about it. But it's also so important to keep in mind that some patients with mild cognitive impairment, maybe a third or even more of patients with mild cognitive impairment, do not progress to sort of worsening dementia. And so it's really important to find the right balance of reassurance, but concern when a diagnosis of mild cognitive impairment comes up. So back to our patient, he scored 23 out of 30 on his MoCA, but he is still fully independent in his activities of daily living. His wife does report that he is repeating the same question over and over again, and that there have been at least 2 times when he became disoriented in what should have been a familiar surrounding to him. And so it is the appropriate diagnosis for him would be mild cognitive impairment. And so the question is sort of, what do you do? So should you refer him right off to to see a dementia specialist? And maybe, I mean, it's really a shared decision with patients. If you do, you want to prep them up, and attached to this segment of the series is a handout of pearls to help your patient to prepare them for a visit to see a dementia specialist. You really want to do some kind of preparatory work like that if you do send them, to avoid bad experiences. But really, most patients, at least initially, are reluctant to see a specialist right away. They may sort of be still struggling with insight into, I don't really want to think of myself as having a memory disorder. You know, why do I need to go see this specialist? And so it is okay to hold off on a referral for many patients, at least initially, unless there are red flags. So if somebody is having other odd neurological symptoms, or they are under age 65, those are people who really do need a neurological evaluation sooner rather than later. You know, and the age is so important because it is so rare. It is very unusual for people to develop progressive cognitive impairment before age 65. Really sort of suggests that there is something, that there could be some other odd, weird neurologic syndrome occurring, in which case you really want somebody to see a specialist. But again, for many people, it's really okay to work this up and follow it, to build trust with people, to educate patients and families about it. But you also do want to be aware of atypical dementia symptoms, which is a good time to talk about what are the 4 main types of dementia. So we all know Alzheimer's disease. Alzheimer's disease is the type of dementia that the public really associates with dementia the most. And really 2/3 of people with dementia have Alzheimer's type dementia, in which short-term memory loss really is the main presenting symptom often at, at, uh, at, um, at when people first do uh, uh, present with this disease. The next most common type of dementia that is actually really important to know about is Lewy body dementia, which has an odd symptom to it that is relatively specific to Lewy body dementia, which is visual hallucinations. So most people with Alzheimer's disease do not have visual hallucinations, but most people with Lewy body dementia do have visual hallucinations. So it really is a discriminatory symptom that people can have that really should make you think about Lewy body dementia. And that's actually such an important type of dementia to know about, because it has really important implications for how we're going to treat somebody's dementia. And we're going to talk about that at a later segment in this series. Frontotemporal dementia is quite rare compared to the other two. This is the most common type of dementia in early age onset dementia. Vascular dementia is kind of a complicated story in that we have really come to realize that the mini stroke, the micro stroke vascular dementia as a standalone cause of dementia is actually quite rare, that much more commonly people have a mixed type of dementia, which is most often a combination of Alzheimer's disease and vascular dementia. So it's not that micro stroke vascular dementia doesn't have a definite important role in most cases of dementia, but as a standalone etiology for dementia, really quite rare. So our 82-year-old man who has mild cognitive impairment, sort of what should we say to him? And you know, that's really the next segment of this series, which is communicating the diagnosis in an efficient and effective way for primary care. Again, here is my email address. Feel free to send me questions, and feel free to check out the two associated handouts that go with this segment, which are the pearls for referring somebody to a dementia expert, and also you can also look online easily to find a copy of the AD8 form that you could use in a validated way if you didn't want to just remember the 3 questions to ask patients. Thank you so much. Thanks for listening. And again, this is Barak Gaster, Dementia in Primary Care.